All excited about this pink rose in my pocket. I know when you first look at it, you're going to say, well, what in the world is Habersham doing? Say, you know, a blind person must have dressed him this morning. Well, no, that's not the case. I've got a pink rose in my pocket because this pink symbolizes something that's going on not only for this month as it relates to awareness, but all year and all day and all month long. And of course, this signifies as a symbol of breast cancer and breast cancer awareness. And since I didn't put my pink tie on like my guest here, you know, I felt a little left out. So I found this pink rose to put in my pocket because I, too, like Dr. Dale here, you know, want to emphasize the importance, significance, and the approach, and the cures, and the statistics, and a whole lot of information regarding breast cancer. This is a call to action.
A call to action.
I'm your host, Alex Habersham, and I'm happy I can take this pink rose out of my pocket now so you won't be laughing at me anymore. But I'm happy to have with me today Dr. Paul Dale, who is a physician, and rather than my trying to do a bio, tell us a little bit about yourself.
Be glad to. So I'm a cancer surgeon. I'm a surgical oncologist.
Wow.
I did my dental surgery training right here in Macon, Georgia.
All right.
I went to to do my fellowship, my cancer specialty fellowship at the John Wayne Cancer Institute in Santa Monica. Graduated from there, and I came back in 1995 and opened my first practice. I was the first surgical oncologist south of Atlanta.
Now, oncology, that means cancer, doesn't it?
It does. It does.
Study of cancer, cancer treatment, and things of that nature.
Absolutely. And that was what I studied for 2 years. Just
wow.
As a general surgeon, I said, you know what, I want to learn more about cancer. And today, I just take care of cancer patients. I don't do hernias. I don't do gallbladders. I do cancers. Yeah. And I'm a specialist that just does cancer.
Now, in doing cancer, that means that you are oncological surgeon.
Correct.
And you do the removal of the lumps, and unfortunately, sometimes you have to remove the
whole breast.
The whole breast.
Unfortunately, sometimes.
Yeah, but I mean, you can live without a breast.
You can.
You know, and I'm sure that you got several stories of people who have done so.
Yeah, absolutely.
So let's talk a little bit about breast cancer. You know, like, I know you may not know the original origin, but how it has transformed and maybe progressed, particularly as it relates to the treatment. Now, I heard somewhere, why this is important, that 1 in 7 women, man, that's pretty high.
That's real high, isn't it?
Yes, sir.
It's very high. So we've seen a steady increase. Actually, the breast cancer was originally reported way back in pre-biblical times.
Wow.
We've known about it for a long, long time. It's been affecting women, but it's increasing. The incidence has increased, especially over the last 100 years. We've seen an increase, a steady increase in breast cancer incidence, and we're not quite sure why. We know that in the 1970s we saw a big jump because we started looking for it a little bit better. We started doing mammography. But prior to that, ladies would come in with big lumps or they felt it or whatever. And so it wasn't until the 1970s we started screening, and therefore we saw a little bit of a bump in the incidence. But absolutely, you're right. 1 in 7 women at some time in their life will develop breast cancer. So that's a significant amount. That's just like in men, you know, 1 in 6 men is going to get prostate cancer.
Wow.
So we're at increased risk for getting those 2 cancers.
Now, do you think, not cutting you off, do you think maybe societal or environmental factors may be contributory factors?
It may well be. It also may well be that we're living longer. And therefore we're getting
cancer got more time.
That's right, and we're treating other diseases. If you think about back 200 years ago, the average life expectancy may only have been 50 years. Well, now 70 and 80 is not even old, and so as we get older, our body's more prone to getting prostate or breast cancer. And a lot of ladies, fortunately, are going to die probably with it than from it. In other words, as they get older, those older lady cancers aren't quite as aggressive as the younger ladies' cancers that tend to occur in the 30s and 40s.
Well, I'm glad you said that, because that's a good segue into, you know, like the age factor. And we'll talk about other factors. But, I mean, when should one start to check for breast cancer?
Great question. So, I would say, well, does that someone have a family history? Because if they do, then they're at increased risk. Now, a lot of ladies will think, well, I don't have a family history, therefore I'm not going to get breast cancer. Interestingly enough, 70% of all women who get breast cancer have no risk factors.
Wow.
Other than the fact that they're women. They're women, and they're going to get a breast cancer.
So even if their family, even if they don't have a family history and they don't smoke and, you know, other things, right, they still have a...
They still have the chance.
Yeah, wow.
So therefore, how soon should we start screening? And the answer is, once you hit 40, a woman should have a baseline mammogram. And depending on her family history, depending on her other risk factors, then she should have a mammogram at least every year or every other year for the rest of her life. And I think women should talk to their doctors. I personally prefer that they have them every year. The American College of Surgeons, every year. But and the American Cancer Society, every year once you hit the age of 40. So screening is important. Why is screening important? Because if we could find breast cancers on mammography that are so small they haven't even got the chance to spread, we could cure breast cancer. So if we could get out
by
there,
removing it,
by removing and treating it early. So anytime you can find a cancer before it's big enough or has broken through the blood vessel into the blood vessels that it allows it to spread, then you've got an excellent chance of living a good long life.
So does it start kind of like as a individual and independent growth?
It does.
And then as it grows, then it begins to invade.
Exactly.
You know.
And that's what we call invasive cancer. Invasive cancer is different.
I'm not trying to be the doctor here.
You're doing a good job, though. So,
I stay in my lane. No, I stay in my driveway, okay?
So invasive cancer means that it has gained the ability to spread. Versus non-invasive cancer is still in its place. It's called cancer in situ, in its place. And that's the kind of cancer we like to find, because that's the kind of cancer with the right treatment, by removing it, and perhaps radiation and other therapy, we can cure it.
So even if it's in its place, you still need to, one still needs to get it removed.
Absolutely.
It's going to grow.
There you go, because it's going to get out of its place.
Yeah.
And it's going to become invasive.
Yeah.
And therefore you're going to be in trouble. That's why mammography is important.
Right.
Because we're going to find it earlier, we're going to find it smaller.
Talk a little bit about mammography. You know, I know that hopefully most women know about it, but talk about the procedure, the danger,
sure,
you know, the expense, you know.
Yeah, absolutely.
How much of a problem it is to get one, and where you can go and get one or whatever.
So the answer is that mammography revolutionized the screening concept for breast cancer. And it started in the 1970s. And in the 1970s, they'd take two pictures, they would put them on a Polaroid film, and you'd have a picture. And it wasn't until about 1990s that we started with digital mammography, just like a digital camera. So all of a sudden, you don't have to have the film stories that you used to have.
I understand.
So mammography's done, and they basically do two films. They do two projections. They squeeze the breast this way and squeeze the breast that way. And when I say squeeze, they squeeze. And women say, why are you squeezing my breast so hard? Actually, the reason is that you've got to get a good picture. And the more you squeeze, it gives you a better look inside that breast. So the government, the actual government, sets the amount of pressure. So it's not, oh, we're going to squeeze this one hard and that one not. Everybody gets the same squeeze. So it can be a little discomforting. You could take some Advil or Motrin the morning of, but most women do fine with it. And where can you get it? So if you live here in Macon, there's many places you can have your screening mammography. I like to suggest you come down to our cancer center and have it done at the Peyton Anderson Cancer Center. We have a breast center which allows comprehensive treatment for all issues that are related to the breast. What about if you don't have insurance? Could you get a mammogram? We actually do have the capability of getting women mammography, even if they don't have insurance.
You might need to repeat that, because I'm sure, it's strange, Doc, and I'm sure you will acknowledge this. A lot of illnesses and death and diseases and treatment, are tied to the economic status.
They are.
It's very unfortunate.
They are.
That a lot of people don't live as long, frankly, because they don't have access to health care. But I think all of us need to realize that maybe there are some things that, people say it's expensive, but, you can't replace your life.
That's right.
That might be something that you might want to sacrifice for survival.
Good point. So what is it out of your pocket if you, say for instance, you just came in and said, I want to get a mammogram. It's about $120 to get a mammogram, all right? So like I said, but if there are programs where if a lady feels a lump, or we can actually get them into the system and get them help and get them diagnosed if that's what it may be. And fortunately, a lot of the times when they feel a lump, it's not a cancer. It's a benign process. It's a cyst, or it might be a benign tumor. So not everything has to be cancer. Not everything they see on a mammogram is cancer. And of course the lady gets a call back and says, oh, we see something, we need to do more tests. Well, what's the first thing they think of? Oh, I got cancer.
Right.
So it's a very scary thing. But a lot of times, keep in mind, a lot of times that something they see on that mammogram isn't going to be a cancer.
Right.
It could just be a benign process. But getting the mammogram is most important. So there are methods. If they call the Peyton Anderson Cancer Center, there are ways to get mammography for women who don't have insurance.
Yeah.
So keep that in mind.
At any rate, everybody needs to get one.
Everyone,
particularly women who are 40 and above.
Correct.
And now let me ask you this. Talk a little bit about the advantages of early detection and the dangers of not getting early detection. And I know that, I forget her name, Angelina Jolie.
Yes.
Is that her name?
Angelina Jolie.
She had hers removed. I think it did not have any.
She didn't have cancer. She had a genetic predisposition, meaning that in her genetics, she was going to get cancer, 80% chance that she was going to get a breast cancer. And she said, you know what? Before I get that breast cancer, I want to do something proactive. And that's why she removed her breast. And she had reconstruction. I have many of those kind of ladies in my practice. Young ladies, all the way from their 20s. And sometimes it's a dilemma. They've got to think about, what do I want to do? I want to have children. I want to breastfeed. I want to have a family. So a lot of them will delay until they've had their children and breastfed, and then consider it.
Now, how do you tell the predisposition?
So,
what's that process?
So
because let me tell you, this is what we're trying to do. Dr. Dale and Alex Habersham are trying to reduce the incidences of death from breast cancer, reduce the incidences of waiting too long for treatment for breast cancer, reducing the incidences of not getting mammograms.
Absolutely.
To see if you've got breast cancer.
That's right. Awareness.
Yes.
We're here to raise awareness.
Yeah.
Absolutely.
So the predisposition.
So predisposition can mean you have a mother with breast cancer, but it doesn't. It can even go beyond that. So if you have a mother with breast cancer and she was 65, then your risk is only 1.5 times increased. If she was 40, it's 3 times the normal population. But if you have the breast cancer gene in your family, it's 12, 14, 20 times the normal population.
So you can have breast cancer and not have the gene. You can develop it later in life.
In fact, probably only about 1 in 10 women or even smaller than that, have the actual genetic predisposition.
Now, is that a test?
Yes, there
A
is.
blood test or something of that nature?
Yeah.
That can determine whether you are predisposed?
There is. There is.
Wow.
And what we do is, and it's not even a blood test. You just come in and you see we have a genetic counselor at the cancer center. Her name is Darcy, and she is wonderful. She's worth her weight in gold because she can explain a lot of these genetic predispositions to patients. All she does is swab the inside of your mouth and send it off. And they do an entire panel of different genes that we know predispose you to get cancer. And if you don't have those, then your cancer just happened because
Age and
whatever. That's right. But you didn't have the predisposition. We don't test everybody, and I don't want us to sit here and say everybody needs to go get tested, because we don't, because I just told you only a small amount of women do. But if you have a sister and a mother and a grandmother and aunts and uncles that have breast cancer, oh my goodness, then you may be at high risk and you may need to know.
Now, do you need to do both of them? Do you need to do the mammogram and the swab, or should
So mammography is important for screening, right? And the swab is important to tell you if you have this genetic deformity. That's a totally different ball game. If you've got that genetic deformity in your body and you're going to get that high of a risk, then you may need to have more than mammography. You may need to have an MRI, or you may need to talk about possibly removing your breast, doing what Angelina Jolie did. So there's more options if you're in that predisposition group. But the average woman needs to make sure she gets her mammogram. The neat thing is we just came out with a new kind of mammography too, and it's called tomosynthesis.
Say that again.
Tomosynthesis.
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 Almost like photosynthesis.
Almost. It's that tomo in the front.
Okay.
What that is 3D mammography.
Wow.
3D mammography. So all of a sudden, instead of taking a picture this way and a picture that way, it's like taking a picture, and it's like, imagine if you had a loaf of bread, and I stuck a raisin in that loaf of bread, and I tried to picture it this way and this way, I might be able to find it. But what if I took that loaf of bread and cut it in 2 slices?
Oh, wow.
And every single slice, I can look and say, oh, there's that raisin right there. So tomosynthesis, 3D mammography, cuts the breast up like that and has a better look inside that breast. And that's why we're recommending, especially younger women with dense breast tissue, consider having a tomosynthesis.
Now, what you mean? You mean with the larger breast? When you said dense breast tissue?
Dense breast tissue means that usually, here's what happens. So when a woman's in her 20s, then she's probably going to have babies, and there's a lot of breast tissue there ready to make milk.
Right.
Because that's what the breasts are for, to make the milk.
Right.
Well, as they get older, the breast tissue kind of goes away and forms scar tissue, so it becomes less dense or less thick.
That's why you get the...
And you can have drooping and
Some
things
drooping.
like that. That's right, that can happen. But as you get older, your breasts become less dense. But when you're younger, that 3D mammography is a wonderful way to look at that breast a little bit closer. It's a little bit more expensive right now, but we're trying to reduce that cost. And I think in a year or two, it won't be that much more than a regular mammogram. Right now, it's only $50 more than a regular mammogram.
Now, will that be covered in most instances by insurance?
It is. It will be. But we've got to do a little bit more. So you may have to pay have your insurance on your mammogram, and then you have to pay a little bit more to get the
I
tomo.
understand.
Yeah.
I understand.
But I think in the future I'm going to get tomo.
Yeah, that's very good. Well, let's talk a little bit about lifestyle
Okay.
and its effect on, we've talked about, certain conditions genetically and otherwise that will contribute to the possibility of one getting breast cancer.
Right.
Or are there any lifestyles? Or?
There are some lifestyles. We found that it's very interesting that.
Let me ask you a question.
Sure.
How did you know it just seems like you're so into this. How did you know this is what you wanted to do?
I was very blessed.
What contributing factor influenced you to want to delve into oncology, particularly the breast cancer element?
I really find oncology patients very appreciative and very interesting to me. I enjoy the complexity of cancer. And I enjoy the concept of taking care of a patient for a long period of time. If I fix your hernia, I fix your hernia. See you later. Whereas if you've got breast cancer, you're going to come see me for a long time. We're going to be buddies. We're going to be friends.
But you're going to keep checking.
Because I'm going to keep checking.
Well, that's a good segue. And let's see, I was asking you another question I think about. Oh, lifestyle. But let's talk about treatment after one has found the breast cancer.
Okay.
You know, because I know that there are instances where people say that they are cancer-free, but at some point, you know, then it kind of comes back.
It could come back. It could come back. But you know what? Saying you're cancer-free is a good thing.
I know.
And keep this in mind. More than 25% of all women who get diagnosed with breast cancer are going to live a good long life, cancer-free. We're curing 75. Only about 25% of women are going to die of their breast cancer.
Now, what role does early detection play in that?
Extremely large amount. That's why we've seen an increase in longevity or a decrease in the death rates from breast cancer because of two things: mammography, and there's a new treatment called tamoxifen. It's a pill. It's an anti-estrogen pill, and that reduces that chance of that cancer coming back by 50%. Not chemotherapy. This is a pill. So
now they take the pill
after they've been diagnosed.
After they've been, you can't take the pill and not
no,
get it.
we don't have a preventive one. We don't have a preventive one. You know, you asked about lifestyle. There's not a lot of you know, we think that keeping weight under control, because obesity increases your estrogens in your body. Another thing is it's interesting how the estrogen cycle, if it doesn't get disrupted, that increases your risk. So starting, if a lady starts to have periods, or a young girl starts to have her periods really young, or she goes a real long time, then those are increasing risk factors. It's very interesting.
Now, so estrogen is a contributing factor to
developing breast cancer,
and it's related to the menstrual cycle.
That's right.
You know, so if in fact you're still in that cycle, then your chances are more likely that you'll get it.
The longer you have a menstrual cycle that's uninterrupted. So if you have a child earlier, then that reduces your risk. We used to think, and some people still think, that breastfeeding.
So you're saying that women who have children
have a lower risk.
Have a lower risk of getting breast cancer.
That is correct.
Wow.
And that's so.
Yeah.
Yeah.
That's
women who've never had children have a slightly higher risk of getting breast cancer.
Yeah.
It's a slight, but it does seem to matter. It does seem to matter.
That's very, very interesting. Well, how can one you know, let's talk about an approach to really learning more about breast cancer, an approach to getting checked out, an approach to what maybe the community can do, organizations, churches, and other entities can do, although this is Breast Cancer Awareness Month, October. What can be done from maybe a community and perspective and an educational perspective to try to, you know, address this problem?
Yeah.
Since, you know, it can be dealt with.
It can be dealt with. Right. You're absolutely right. The earlier we find it, the better off we are. So one of the things, doing what we're doing right now, bringing awareness. That's number one. Bring awareness in the churches. I've gone to many church groups and given talks about breast cancer.
Will you still do that?
I still do that.
Will you continue
I will
to do
continue to do that. Absolutely. I enjoy doing that.
Dr. Paul Dale, ladies and gentlemen.
And I continue to do that. And I enjoy doing that.
Right.
It's an important part of civic duty to get out there and tell people about it. And it's a scary. You start talking about cancer, it's a scary word, you know? But let me tell you something. Women will talk about it before us men do. And women are vocal about their cancers. And when they have their cancer, they're not afraid to say, I've got cancer, I'm going to beat cancer. They go to the government and they say, guess what? You're going to give us some money for research. And most of the cancer research done today is because women have gone and says, give me some money to treat cancer research. Not because men say, I want my prostate cancer treated. No. They won't talk about that. But women will. And so therefore, a lot of cancer research is being done. And a lot of good things have been found out from the research of breast cancer. Because the women speak up.
Let me tell you what comes to my mind. And I think that kind of underlines what you're saying. When they have these forums and these activities for cancer survivors, you know, they are not shamed. You know, I bet you if you had it for prostate, you know, some guys might shut up.
Yeah.
But they are not ashamed.
They're not.
And, you know, they seem to be very proud of the fact that they are survivors of breast cancer.
Absolutely they are. Let's talk a little bit about treatment.
Go ahead.
Let's talk about treatment. So for years, 100 years, so let's go 100 years ago, say 100 years ago, there was very few treatments. There was surgery, there was a mastectomy, and that was about all we had. So 100 years has come a long way, and now we know that we don't have to necessarily remove the breast. So just because you have breast cancer, you don't have to lose the breast. You don't have to have a mastectomy. If you do, because of the size of the tumor, or you want a mastectomy, you can have reconstruction. We've got incredible surgeons who do some great plastic and reconstructive surgery right here in Macon, Georgia. Do a good job. So even if you had to lose your breast, reconstruction is an option. The women who don't lose their breast, yesterday I did 2 breast cancer surgeries on 2 ladies that says, you know what, I don't want to lose my breast. I've got a relatively small tumor. I want to save my breast. So what does that mean? I go in and I just remove the tumor. Now after that, they have to have more therapy. They have to have some radiation. But you know what? Radiation is not that horrible.
They take the pill too?
No, they could take the pill too. That's right.
Yeah.
So they get radiation where they X-ray where I did the surgery to sterilize that area,
right? And
then they may get put on this pill called tamoxifen, the anti-estrogen pill. Some ladies actually do need chemotherapy, and when they do, you know, they're scared. They're very scared, and I say, you know, most of the time I say try it one time and see what happens. And they'll get through that first treatment, and before they know it, they're done with all the treatments.
Wow.
All 6 treatments are gone.
Wow.
And they said, Dr. Dale, you're right. I got through that, and here I am a stronger person from it all.
Well, I'm sorry, but we're just about out of time, Doc. And this
time flies.
You know, I'm so happy. I want to thank you.
Well, thank you.
You know, for your interest and your dedication to what you're doing. I want to thank you for imparting the information that has educated me. And I'm sure the same is true for our listeners. And very quickly, can you give a general number where a person can call to find out more information?
Sure. If they're concerned, they can call 478-633. 6900 is my office number. And if they can't help you out, they'll direct you to the main cancer line.
Yeah, that's outstanding. This is a call to action.
A call to action.
This is a call to action.
A call to action.
I'm your host, Alex Havisham. I'm having interviewed Dr. Paul Dale, oncologist, and that's one who specializes in cancer treatment, prevention, and etc. I really appreciate it, Doc.
I appreciate you having me.
Thank you.
Anytime in the future, call me.
Yes, sir.
Love to do it again.
Yes, sir. Have a great day.